My pleasure to welcome you today. I'm Patrick Rossignol. I'm nephrologist professor of therapeutics working in Monaco. And it's my pleasure to introduce you to this e-seminar led by EuReCa-M, the Cardio-Renal Working Group of EuRe. And today we have an outstanding faculty speaker from Sweden, Juan Carrero, and two panelists, Annette Bruchfeld from Sweden and Alberto Ortiz from Spain, and with a very provocative title, Let's Talk About Sex, Disparities in the Outcomes and Quality of Care of Men and Women with Kidney Disease. We have 1 hour to spend with our speaker and panelist. On Juan Jesus, the floor is yours.
Thank you, Patrick. Good afternoon, everyone. Thanks for joining today's seminar. Let's talk about sex. And now that I have your attention, let's talk about the differences between men and women in both outcomes and quality of care in the context of chronic kidney disease. First, I have to report my disclosures, a couple of seconds for you to read through, and we can start. If we talk about sex differences, we have to talk about gender-based medicine, and this is a new discipline that I think is a bit misunderstood. When I talk to my colleagues, especially the old generations at the clinic, they raise their eyebrows and say, well, this is rubbish. This is just a bunch of angry nurses and doctors complaining about their salary inequalities. This is just women telling that they are discriminated, mishandled, forgotten, or that they want more medications. In no way this impacts my clinical practice, and I treat all men and women exactly in the same way. And that is the problem. The problem is that men and women are not the same. Gender-based medicine embraces the fact that we are different, that we have different genetic background, half of the chromosomes, we have different reproductive organs, we have different hormones, and this may impact in how two sexes may experience the same disease. We could have differences in pathophysiology, respond differently to therapy, or tolerate and cope with the disease in a different way. But on top of that, we are bound to stereotypes. We are brought in a society, we have behavioral expectations of how we should act, what is expected from us, and how should we perceive others. And this is at all levels. I come, for example, from Spain, where the moment you are born, you are given clothes in pink and in blue to make sure that everyone knows whether you are a baby boy or a baby girl. When I was young one, I got this toy for Christmas that had a button behind that would say, by the power of grade school. And instead, my cousin Gloria got this other toy that said, have you seen my boyfriend Ken? Obviating that these differences have existed in our upbringing is a very naive point of view, because it also impacts in how we see and we perceive our patients. For example, there is research showing that a man reports to have less pain when the doctor or the nurse is a woman. And that there is research showing that female doctors are more critical towards their patients when they are male. Now, if you're interested in these two topics, I suggest that you read these reviews of recent publication where I was given the honor to participate and provide an overview also on the topic of kidney disease, but much beyond. Now, gender-based medicine is about both men and women. And then it's important to talk about what is not gender medicine. Studies about pregnancy or prostate cancer is not gender medicine, that's gender-specific medicine. It only affects one of the sexes. The situation of female healthcare professionals is also a very important topic, but it's not gender medicine, it's gender equality. Great, and what's it for me? That's what we have to discuss today. I want to give you an overview of these sex and gender differences throughout the progression and course of kidney disease. And I will follow mostly the outline of these two reviews of recent publication where you can find much more information, examples, and citations. But let's go. In society, there are many more women than men with chronic kidney disease at stages 3 to 5. This became evidence in this figure that we made with the help of Nick Chesnaya in the EDTA registry, showing that in all national registries worldwide, except very few exceptions like Japan, many more women than men have kidney disease. In the Global Burden of Disease Consortium, they estimated that almost 12% of women versus 10% of men have G stages 1 to 5. And I say G stages because they did not take albuminuria into account. And I will come back to that in a moment. Now, this is interesting. Why would there be more women with kidney disease in society? The easiest explanation is that women live longer. They have a longer life expectancy of, on average, 8 to 9 years more than men, and therefore they have more time for the age-related GFR decline. A potential second explanation is that we underestimate GFR in women because the equations that we use impose larger biases in women by the problem of these 1.73 square meters. We are assuming that they have the same surface area than men, and on average, women tend to be smaller than men. This is shown by these two studies, not so far ago, in which they compare the equations against measured GFR, iohexol and iothalamate. And they observe that mean measured GFR is lower in women than men, and that all equations are more biased among men compared to women, leading to the underestimation that I reflected. Whether this is enough to change the view of the description of the disease in society, I don't know, because this study just came last month in JSON, showing that in the absence of disease, women have a lower GFR, this is measured GFR, and a slower age-related GFR loss. This is a study from the Tromsø cohort, 1,800 persons from the general population that underwent routine iohexol measurements. This cohort is unique. And here they perform a number of exclusion criteria of any comorbidity and medication from the list. Patients were free from smoking, did not have diabetes, hypertension, they had a normal BMI, no albuminuria, no cardiovascular disease, no cancer. And you can see that women start with a lower GFR and the decline is less rapid in the red. Now, this made me think, but it's not so different than what happens in the presence of disease also. This is data from the Swedish Renal Register, where you can observe that the risk of kidney replacement therapy or the risk of death before kidney replacement therapy is both higher for men compared to women. And this is a nationwide cohort of patients with CKD stages 3B to 5. This to me brings a number of open questions that if you are interested, we can take during the discussion. If women have a lower GFR and also a slower GFR decline, should we define prevalence, progression, and the therapeutic targets in the same way as men? What is there in women that makes the GFR loss less rapid? And conversely, what drives the more rapid GFR decline in men? And for that, brings to another topic, which is albuminuria. This is a data that will appear in press in the next couple of weeks, but here we have tried to evaluate the prevalence of chronic kidney disease in the region of Stockholm, taking albuminuria into account, and because there are indications for testing albuminuria, we waited for the inverse probability of being tested. Now, keeping the long story short, what we observed was a bit surprising. I told you earlier that there were more women in society with kidney disease stages 3 to 5. But when we add albuminuria into the equation, because albuminuria allows you to classify stages 1 and 2, and stages 1 and 2 are prominent, then the prevalence shifts, and chronic kidney disease is much more common in men compared to women. Specifically, the numbers are inverted. 12% of men and 10% of women may have kidney disease taking albuminuria into account into society. And then when I look at other previous publications like this paper from the PREVENT cohort showing that men were 3.5 times more likely to worsen their albuminuria compared to women, maybe this is something that we are reflecting here because the men are the ones progressing with albuminuria and perhaps dying and not being able to live as much as women. Anyway, would this mean that albuminuria is a more important target for men? Animal studies tend to blame everything to sex hormones, and these are studies where you have either supraphysiological estrogen administration or endogenous estrogen, and it shows in general beneficial effects in the kidney. In other words, animal studies suggest that estrogen is good, and that's why women progress less. Animal studies also give enormous amount of testosterone, and in general, there are bad effects. So in a simplified way, estrogen is good, testosterone is bad. However, I think that life is much more complex than animals. Mice are not humans, and the data in real-world practice does not seem to reflect this effect of hormones. Look at these two observational studies, both of them in very well-reputed journals, showing that estrogen replacement therapy and oral contraceptive use associates both with higher and with lower risk of CKD progression. You can look at this randomized control trial in JAMA, showing that androgen deprivation is associated with a higher risk of acute kidney injury in patients with prostate cancer. I think it's difficult to discern what is the chicken and what is the egg here, because in kidney disease, testosterone levels will go down with more severe CKD. And the incidence of CKD and the progression to kidney failure occur in the elderly, who per definition will have lower levels of testosterone. But then there are a lot of studies showing that within patients with kidney disease, those that have higher testosterone compared to lower, they have less anemia, more muscle mass, lower cardiovascular risk, and lower death risk. So things do not seem to match. The grass is not always greener at the other side, and we need to remember the stereotypes, the expectations, and the societal view. For example, data from the US RDAs and Australia and New Zealand show that more women than men choose conservative care, perhaps because more elderly women live alone and they do not have partners to take care of them. This thing of getting married or being a widow, it's also funny. And I put this study that was published in the month of September, basically maybe to corroborate that we men do not know how to take care of ourselves. This is data from Haynes, and you can see that compared to married men, which is a reference category, unmarried men, they have a much higher risk of death, whereas women's death risk did not differ according to marital status. Many years ago, Joseph Koresh published also from Haynes in the US that women with kidney disease were less aware of having the condition. And this always made me think why women would be less aware than men of having a condition so serious as kidney disease. Are women really less aware? And with the help of Sebastian Helsmesser and Manfred Hecking in Vienna, we revisited this study in the enhanced population, looking at trends over time. And you can see in the first figure that the awareness of kidney disease has always been lower since 1999 until 2018 among women, on average 25% lower. But especially the good thing is that trends are improving over time, and these differences that were magnified at the early years are becoming closer. Still, it didn't solve the problem, because why would women know less? And then I went into the question that ascertains the awareness of kidney disease in Haynes. And the question that the patients have to report is this one: have you ever been told by a healthcare professional that you had weak or failing kidneys? And that made me think that maybe the problem is not in the women knowing or not knowing, is that the doctors have not checked or have not tested. And then we did this study that you can find in JSON in the month of October. We evaluated indicators of recognition, monitoring, and management of chronic kidney disease in primary healthcare in the region of Stockholm. I'll tell you what we did. We identified all persons that have ever first detected EGFR below 60 in our health system, the first time that the EGFR was below the threshold. And then we looked into the processes of care between men and women during the following 18 months. What we observed first is that the rates of detection, recognition, etc., they were low, consistent to most of other societies, but they were particularly low for women. For example, given the first diagnosis of EGFR, the first measurement of EGFR below 60, only the women were 57% less likely to receive a diagnosis. They were 25% less likely compared to men to get another test of creatinine in 18 months or another measurement of albuminuria. They were 54% less likely to be referred to a nephrologist and 45% less likely to start RAS inhibitors or to receive statins. This was a bit of a shocking scenario. Why is this happening? Is this a problem of Sweden only? And when we started to look into the literature, we found usually hidden in the secondary materials, in the supplemental tables, data that seems to suggest that similar processes are taken care, for example, in the UK, in Canada, or in the US. Now, why is this happening? Why do we fail to recognize women with chronic kidney disease in healthcare? Is it because of the challenges of interpreting creatinine in women who are on average they are smaller and have lower muscle mass? This probably doesn't explain the situation, because nowadays we have automatic reporting of eGFR in most health systems, so this should not have been a problem. Is it because we as healthcare professionals have unconscious biases operating and believing that men are, the CKD in men is more severe than in women, and in women is less problematic, we can skip? I'm not aware that we would be like that, but I would be happy to know your opinions after during the discussion. Is it that women patients themselves more often deny their disease? In any case, guidelines are clear and they make no distinctions by sex as to who should have a diagnosis or who should be monitored after 90 days. Regardless of what problem is going on, it can and it needs to be fixed. And regardless of, despite of all these reasons, the consequence is that men progress faster, women progress less, more men than women start dialysis every year in a proportion of 60 to 40%. And this leads to the second point of the presentation: what happens during dialysis? And in the general population, we know that women have a longer life expectancy than men. We already said that, and a lower cardiovascular risk, as shown in this old figure of coronary disease mortality per 100,000 patients across all countries in the world. Now, chronic kidney disease is a disease linked to cardiovascular disease. It's a disease where men progress faster to end-stage kidney disease, and twice as many men start dialysis. If we put all the things together, we would see that this survival advantage of women, or this increased cardiovascular mortality of men, should be very well maintained. However, the surprising thing is that when men and women start dialysis, they survive just the same. This is one of the many studies that we did many years ago in the NECOSAT cohort in the Netherlands. Now, this has been referred to as the cancellation of the female survival advantage. And a recent paper in the British Medical Journal by Nicole de la Mata from Australia gives us shows this in a very nice way. It shows that the life-limiting impact of dialysis affects disproportionately women compared to men. What they did is to collect all incident patients on dialysis in Australia and New Zealand in a number of years and compare them with the mortality rates of the general population. And they observed that the risk of death was the same between both sexes, as I told you, but compared to the general population, women with kidney failure had much more excess deaths, specifically a standardized mortality ratio of 11.3 than men who had a standardized mortality ratio of 6.9. Women with kidney failure, they lost on average 3.6 years more of life compared to men. Now, I always thought that this is very weird. Why don't we make more effort in understanding what's going on? Because understanding the reason for this cancellation of the survival advantage can give us clues into what can we do better, what can we prevent. One possibility is that women die more rapidly because they reach dialysis with a worse cardiovascular profile, and this excess cardiovascular risk doesn't match up with whatever advantage they may have received. No, it's not the case, because in all papers that I've been able to find, men reach dialysis with a worse cardiovascular risk profile. They more often smoke, they have more obesity, worse blood pressure control, left ventricular hypertrophy, calcification, secondary hyperparathyroidism, dynamic bone disease. Another possibility then is that the causes of death are different. And this paper we did a lot of years ago already. I realized how old I'm becoming, in the EDTA register, where we look at the relative risk of women versus men according to the type of death: all-cause mortality, cardiovascular mortality, and non-cardiovascular mortality. This is the relative risk women-men. So risk above 1 in orange reflect increased mortality for women. Risks below 1 in blue reflect increased mortality for men. What you can see is that the preservation of the lower cardiovascular mortality risk was observed in women of old age, perhaps after a long life of receiving estrogen during their pregnant years. However, in the young population, we have an increased risk of mortality, mostly explained by non-cardiovascular causes. We spent some years trying to figure out what non-cardiovascular problems are occurring. In the EDTA register, we observed that both infections and malignancy were more common in these young women, and we confirmed this in the Andalusian Registry of Peritoneal Dialysis. Maybe it's more nicely shown in this paper that came in August in American Journal of Kidney Disease, also from Australia, because it gives you a perspective of when the events happen over time. What you can see in the first figure is that the women, compared to men, they have a higher risk of death, particularly during the first 5 years of dialysis, which is explained to some extent by infection-related mortality. It's not explained by cardiovascular risk because it continues to be lower compared to men. And then unique to this population is information on dialysis withdrawal. And again, more women in this setting, in Australia and New Zealand, seem to withdraw from dialysis, and that may be a cause of their mortality. The questions that these studies evoke to me is, should we focus on infection prevention as a target for women? Why do women withdraw from dialysis more often than men? A third possibility is that the quality of dialysis care that we are given to women and men is different. And for that, I want to tell you about some inherited myths. One myth has to do with arteriovenous fistulas, which, as you all know, is the preferred choice for permanent access. Now, a paper in 2003 came in Kidney International showing that women in the US were less likely to receive arteriovenous fistulas compared to men. And they argued this is because the physician is afraid of the smaller vessels of women, and women maybe don't choose fistulas because of aesthetic reasons. Well, that same year, another paper in American Journal of Kidney Disease demonstrated using Doppler ultrasound that the diameter of the vessels is the same for men and for women. So it's not a biological problem. It could be an aesthetic problem, but mainly it may be a problem of doctors' training. If we inherit this belief and we don't practice enough, we will not be giving arteriovenous fistula to women. Now, 8 years later, another paper showed that still women on dialysis were less likely to receive arteriovenous fistula. 5 years later, another paper in DOPS showed that this is something general that occurs basically in almost every country contributed to this register. When I see all this panorama, it seems true that men are just falling on the same stone over and over again. Because another issue that we need to be aware of is that we should not assume that men and women are just the same. And this can be a good example, estimating the amount of dialysis through our KT over V. The problem here is V. V is a constant value that assumes that that both sexes have the same muscle mass. And you know that this would not be true. There are women that on average are smaller, more petite. There are also men that have less muscle mass, but we treat everyone in the same way. And these studies, also published a few years ago, showed that KT over V overestimates dialysis adequacy in women, and that this overestimation, for example, may explain why in the HEMO trial, long time ago also, a higher dialysis dose predicted death among women, but not among men. We have been assuming that men and women are the same for many other aspects, for example, renal anemia. In the general population, we have sex-specific definitions of how anemia should be defined, because men have a higher erythrocytosis compared to women. This is well known, but yet our guidelines in chronic kidney disease have the same targets for both sexes, hemoglobin between 10 and 12, based in part because of the old pivotal EPO trials. Now, this has been reported in a good number of papers that leads to an overestimation of anemia prevalence in women with kidney disease, over treatment, and that women on dialysis end up requiring higher ESA dosages than men to achieve the same hematocrit concentration. This problem is also expanded into drug dosages, because you should know that the dosages of the medication, this 1 pill per day, 7 grams of this or 8 grams or that, they are calculated based on a 70 kilogram man of 45 years old. That's the standard age and body weight. That comes also with a standard body surface area, extracellular and intracellular water. But this is not true, because we know that on average, men and women have many differences in these aspects. Women have a lower body weight, they usually have a lower height, body surface area per definition should be smaller, and the distributions of total body water, extra and intracellular also vary. This we don't take into account, and our treatments are often universal. We seldom take them, vary our dosages according to the patient's sex. And that's why the most common adverse effect that we can find in medications among women is overdosing. Now, all these examples is to show you that we have been describing these changes for many, many years. But if we want to do a change, the change has to start within us. We need to make the change possible. And this leads to the third point of the presentation. How do we perceive and how patients perceive disease? In collaboration with Manfred Hecking and Alison Tong from the SONG initiative, we made these semi-structured interviews to 51 nephrologists from 22 countries. And here I copied some interesting sentences. I will not read all of them, but you can maybe read quicker than I can speak out. For example, some physician said, he, a male patient, has been more than 30 years on dialysis and is alive because of his wife. She puts her family's health over hers, especially those housewives. She may have blood pressure for 3 years and we just think it's a stress and give anxiolytics. If it was a man, we would quickly provide antihypertensive medication. He complains louder, he demands more, and we end up giving him much more attention and treatment. She's more silent. Do you reflect this? Do you feel this also reflects your practice? And how do patients react to their disease? In some studies, it has been shown that women with kidney failure more often report anxiety, stress, depression, and they feel more often that this disease has worsened in their quality of life. Men, however, react with neglect. They adopt unhealthy behaviors, they smoke, they are non-adherents, they have an excessive food intake as a way to cope with the stress of the disease. We reach dialysis bothered by different symptoms and with different comorbid conditions. This was made evident by a beautiful analysis from the EQUAL study showing that women reaching dialysis with an eGFR less than 60 more often reported fatigue and bone joint problems. And men instead were more concerned about their libido or interest in sex. Women on reaching dialysis more often had a diagnosis of stress, more often had psychiatric disorders, malnutrition, or liver disease. Men, however, more often smoked, more often were treated with anemia, and more often, as I showed you earlier, had a history of cardiovascular disease. The same can be seen in dialysis patients. An old paper from Andrew Davenport. 500 patients were asked to report their symptoms associated to the dialysis session. Women more often reported fatigue, cramps, hypotension, headache, and dizziness, and they had a slower recovery from the hemodialysis session. What all this picture gives me is a notion that women on dialysis may benefit from a different and more personalized approach. And this is what gender medicine can do for us. With this, I just want to congratulate you for surviving yet another webinar, as we don't have enough. You have my contact details if I can help you in anything. And I want to acknowledge the individuals that are here in the slide that have helped me to develop some of the studies that I have discussed here today. Thank you very much for your attention, and I look forward to your questions.
Thank you very much, Juan, for this great presentation. So we have time for discussion now. We have two outstanding discussions today. As usual, I would say ladies first. Annette. What are your thoughts?
Okay. All right. So I think, thank you very much for this presentation. I was thinking about what you said about life expectancy, because that has been, the expectancy of life is actually closer now than it used to be. The difference has not completely disappeared, but it's not 10 years. It's maybe a couple of years, something like that. So maybe, and also that women may have adopted some of the more male lifestyle, and like more smoking and drinking and more stress. So what we are studying today may be changing in the future because the women are changing. Like the background factors are changing. What do you think about that?
Yeah, but this reflects only the complexity of what we are addressing, because we cannot blame it to biological sex. It's also everything that comes with our upbringing. And then this, in modern society, when women are now incorporating to work in the same rates and with the same level of stress, and they are getting all the bad things that they maybe should have gotten, things are approximating. So how to separate this is not possible. And that's why gender medicine needs to balance both the stereotypes, the pressure from society, the culture that we are embedded, and the medicine.
Yeah, thank you. So I just want to ask one more question about the way CKD is diagnosed, because I mean, I know that in Sweden we all use much more cystatin C, and it's also reported in the patient file, and then you get 2 measures, and then you're taught that you should like use both and like have an average. But even if the physicians see that, they still don't send the patients to a specialist, and especially not the women. And I find that really, I think it's a pedagogical problem that we need to address, because it used to be in the old days with creatinine only, but now we don't really have any excuse. So we should teach the primary care physicians to be much more aware of this.
I fully agree. I don't think we have any explanation of why this is happening other than it shouldn't be happening. And we are precisely working on this, Annette. We are preparing a decision support system, a triggering system that would help clinicians in primary care to follow these guidelines and to avoid these biases. Whom should be screened, how often, how measured. If we are lucky, we will be able to start this trial next year.
Mm.
Well,
Jesus, thank you very much. This was excellent presentation, and many different points touched. First, I would like to discuss the faster age-associated decline in eGFR in men, because when you look at the graph, it's not actually faster. It's the same rate until around age 60. That there is a change of slope for men, but not for women. So it's not age-associated, speaking as a whole, but it's like accelerated aging once you get to a certain age. So after age 60, there is a change in slope in only one of the 2 genders. Can this be attributed to some subgroup? So many of the men continue along the same line as women, but a sizable subgroup ages faster.
So that paper was a little bit difficult for me to understand, because in order to try to disassociate the disease from the age-related kidney function decline, they perform a lot of exclusions. I mentioned just a few, but they excluded at each visit individuals who smoked, who had cardiovascular disease, diabetes. Now, I think that as we grow old, comorbidities are inevitable. And I suggested to the authors, why don't you just include all the population and then adjust for comorbidities? That would feel, and then that would have allowed to evaluate what you are saying, whether certain comorbidities or standpoints accelerate the decline. But they felt that this was a better way of showing this age, purely age, because all comorbidities are out. But in excluding all the comorbidities, I agree that the resulting population is a very unreal population, because who is free from everything when they are 70?
Yeah, but even if they are free, so the mean values progress faster. But this may be a mixture of people that progress slower and faster. For example, the always stated -1 ml per min per year loss of GFR. There are some people who don't lose GFR and some who lose it faster, and the mean is 1.
Yes, definitely. Yeah, but again, what they show does not disagree with all the other evidence that has included patients with full comorbidities, even if the measure is more imperfect because it's estimated GFR. So I showed you the next slide with the Swedish Renal Register, and there are, I don't know, 15 or 20 studies that would agree with this view. So these regardless of, there was an interesting study from Creek, I remember, that they did sequential adjustment, and they saw that the difference between men and women were more or less abolished when they adjusted for lifestyle factors, smoking, BMI, exercise. And they used that to argue that probably these differences are explained by a more healthy lifestyle among women, which I may be tempted to believe that is true, but the differences in hazard ratios were very small.
Okay. Then the second comment I had is about albuminuria, because you checked the CKD prevalence based on albuminuria in Sweden, and in fact, women, it was less common. But we have to take into account that urinary albumin creatinine ratio actually overestimates albuminuria in women because of the lower denominator. So the actual prevalence of CKD based on albuminuria may even be lower.
Yes, and conceptually, what you are addressing is very interesting, because does it mean, I mean, we have made so much effort recently in redefining GFR in order to exclude the race denominator, but should we think about how to redefine GFR for men and for women if the measured GFR is lower, if the decline is lower, if the albuminuria is less? Maybe what they are doing in Sweden is not entirely wrong. Maybe these women did not need a diagnosis, did not need to start on medications, or did not need to be referred. I think there is a lot here to disentangle first. And on one hand, if we delete the sex from the eGFR equations, at the end we only have creatinine left, and maybe it's just a too simplified view.
Beatriz Fernandez in our center look at head cohort of Fabry persons, diabetic persons, and in fact, one key finding is that smoking was a key driver of albuminuria in people who were fully treated for diabetic kidney disease, and this explained to a large extent differences between men and women. And the second observation is that albuminuria was not a predictor of fast GFR loss. So in these people that have been diagnosed and fully treated with nephroprotection, cardioprotection, albuminuria was still a predictor of rapid GFR loss above 5 ml per min per year in men, but not in women, either single-handedly or adjusted for other factors. So yeah, I think we should look more in depth at this albuminuria issue.
I agree, and to me, this was a little bit of a surprising finding. I didn't emphasize it too much in the publication, but I think it was because it felt counterintuitive to say that now suddenly more men have CKD, but that's because of albuminuria, and that's something we need to investigate further. I agree.
And in this regard, you're familiar with the risk associations of eGFR values and all-cause death, etc., and also for albuminuria. Are you aware that those relationships, let's call it those relationships between albuminuria and events, is different for men and women?
From the back of my mind, I don't recall any study in a specific, but I would believe that such simple stratification has been done in many. We just need to find it. The problem is that these kind of things we always bury into the supplemental materials. We never study differences by sex. It's just one of many stratified analyses that goes into a forest plot in page 76. And that's where we have started to find information there, but it was never been discussed or it has never been brought up to attention. On part because we only want to emphasize studies where women are disadvantaged. I see that sometimes it feels that we only want to publish studies where women are doing worse. But if women are doing better or the same as men, then it doesn't really, maybe it doesn't deserve publication. And I think that we are having a gap in knowledge by this selective reporting.
So I would like to just, I thought it was really interesting about the mortality in dialysis with that women, and it was not sort of the traditional risk factors. The question of more death due to infection. So dialysis, women in dialysis, I mean, you have like estrogen that is like an immune stimulating hormone. And that was fairly clear from the COVID pandemic that men did worse than women, but over a certain age, when you don't have this protection anymore, and you would say that women in dialysis, they have all these hormonal disturbances, they would lose that protection and they would be at higher risk of infection. But there must be more to it, not only that, but that was sort of on the top of my mind that came up.
I mean, that argument does not really stand for cardiovascular protection, right? Because still after menopause, women have a slower cardiovascular risk. And then we say that's because during all their menstruating years, they have received the benefits and the protection of long-term exposure from estrogen. So then when they reach menopause, they are in a much better state than men who have not had this. And the same argument we could address for infection. Why it's happening, I don't know, but it's been clear in at least 5 studies that I'm aware of. They're more likely to have peritonitis, they're more likely to have infections requiring hospitalizations, more likely to die from infections. And as I said, I show you all these studies that have been published year after year or decade after decade, and I don't feel we have done enough to solve it.
Yeah, but the long-term protection is maybe different for cardiovascular disease than for infection. I mean, either you have it or you don't have it. I don't know, but it's interesting because with COVID, the elderly women also did badly.
In this regard, maybe the differences in the availability of fistula may have influenced also sensitivity to infection. So the fact that more of them were not carrying fistula, but catheter or prosthetic, etc.
Yes, it could be one potential explanation. I'm not aware that the studies would have accounted for that. In relation to this comment, there is a question in the chat from Tamara Chenko stating that it's well known that females have smaller arteries than men. And here I have to disagree. I showed you in the slides a paper using Doppler ultrasound showing that the diameter is exactly the same. So this is the perception that we have inherited for many years of medical practice, but is not supported by evidence. The diameter of the arteries is the same between both sexes, and that should not be a limitation to receive fistula. Whether that is the reason of the infections, it could be studied.
Well, if I may chime in, in one slide you mentioned that women may be more reluctant to initiate dialysis compared to women, or more hesitating with regard to the dialysis technique they may wish to implement. Do you have data showing that there may be a delay in initiating dialysis in women compared to men? Or
yes, there is data in the UK register showing that men are referred to the nephrologist at a higher EGFR than women, and they start dialysis at a higher GFR than women. So this would support the statement, but the statement that you refer to is one of the responses of one physician in this qualitative interview. I wouldn't think it's a general view. This was the impression of the physician, and it gives you an idea of how we perceive male and female patients differently.
Okay, and what about adherence to drugs? You nicely showed us some examples, but do you have? It's really difficult to accurately assess adherence, for instance, in hypertension. So, would you say that there are really strong ideas that one gender may be more adherent to another, or in other words, for instance, is blood pressure control better in one gender compared to another, or does it apply, for instance, also to LDL cholesterol target or to glucose control or other risk factors?
Very good comments. There are lots of examples in the literature about this. Specifically to chronic kidney disease, I remember a couple of papers from NDT last year or 2 years ago from a European cohort showing that blood pressure control in men with CKD stage 4 and 5 was worse compared to women. And that was explained in part by poorer adherence. There are data in some old papers in British Medical Journal in diabetes showing that women had a more strict glycemic control compared to men. I haven't seen studies following that. But also we have the perception in general that the best compliant patient is either the female or the married man, because then there is a wife who takes care of their medication prescription. I think that's well, a reasonable perception, but there are also studies demonstrated that women are not so good as they believe they are. I remember specifically a study from Japan where they measure self-reported adherence versus measured adherence, and it was in dialysis patients, and they were looking at how the women said that they would comply with their dialysis session versus the blood urea nitrogen, KT/V, and some objective markers. So when men reported to be compliant, the markers reflected so. When men were not compliant, the marker reflected so. But in the women, everything was more mixed, meaning that women reported to be more compliant than they truly were. And this is also another aspect of gender medicine. We believe that we may be compliant. We live on that inherited perception, but in reality we are not, and we lose ourselves in the process.
Yeah, I thought it was interesting, the symptoms that were reported for women. Also, I guess for dialysis that you know, I don't feel well today, could we shorten the session, and all these things that happen in a dialysis unit. You know, it's and then you would look at this tiny woman and said, okay, fine, where's this big man? You would feel, no, you have to continue your session. All these preconceived ideas that we have that play tricks with us and the patients.
And I think that that's exactly the bottom line, Annette, that we cannot measure everyone in the same way, that each person is unique. And that's what I like of gender medicine. It's to some extent precision medicine, because it means giving to the right person with the right sex, the right treatment, the right attention, and the right perception, and sometimes we consciously or unconsciously may dilute this precision into generalities.
Yes, please go ahead.
Yes. Regarding this UK data that may are referred to nephrologists with higher GFR, when were they generated? I mean, maybe. The referral is based on serum creatinine rather than on eGFR, and obviously men have more muscle mass, so the serum creatinine will go up higher. So maybe it's a question of whether the primary care physicians are using eGFR most recently, or they are still using serum creatinine and as in last century.
Yes, and in this context, I'm not sure how it works in the UK health system. It would be nice to have some panelists from the UK. But the paper, I just looked, the reference is from 2014. so it's not tremendously old, and it's from the UK Kidney Registry report. What are the reasons for referring in the in the UK? I think it would be more than simply creatinine. The same as in Sweden, we would have many other criteria, but I'm not familiar with the specific details in that health system.
However, the UK is a bit special because I don't know where is the wall, but they have patients start kidney replacement therapy earlier than in other Western countries. That, for me, suggests that elderly people are not starting kidney replacement therapy for whatever reason. So we are missing the elderly people in kidney replacement therapy from the UK, and this is more striking in Scotland than in the other countries in the UK.
Thanks. I wouldn't be aware of these differences there.
I just have, I would think, well, the main issue here, I think the main problem is that if women are not acknowledged having kidney disease, I mean, according to the guidelines, they will not be given the new drugs, the kidney protected drugs, and then we will have a real problem in the future. And it's not possible to refer all these patients to renal medicine. We can't take care of all these. So all this has to take place, most of it, in primary care, the awareness and the initiation of treatment. And that's like the big issue, I think.
And this brings to two things. The first thing is that we need to increase the cooperation with primary healthcare physicians, between nephrologists and primary healthcare. And the second is, if you think about it, all the papers that we have evaluated that affect to populations referred to nephrology care, they are just a tiny portion of the ones that were referred. The majority of women are not included in any of our studies. We don't know how they are doing. That should be evaluated. No?
There is a question in the chat for you.
Daniela says, regarding treatment for hypertension, would you comment about differences regarding, for example, physician might not recommend ACE to fertile age women because of possible side effects, teratogenic effects. Therefore, those women would not benefit from ACE protecting cardiovascular effects. Well, while this may be true, I think this explains very little of the populations that I have shown you that tend to have on average an age of 60 to 68 years. So the proportion of women with CKD in fertile age in these studies is negligible. That's my impression. Do you guys have another comment?
No, I tend to agree with you. I'm not sure. Women are actually significantly deprived from life-saving drugs in this setting, since blood pressure control is utmost important, of course, and as long as you get it achieved with any suitable drug, it is fine, especially if you are not presenting with CKD, for instance, in the middle age. And in postmenopausal women, this is no longer an issue. But earlier on, as long as you are able to achieve an appropriate blood pressure control, calcium channel blockers may be more than enough in many women.
I think it's limited, the time that you're off ACE inhibitors. I think it's a bigger problem that many patients are off ACE inhibitors once they're hospitalized for something and AKI, and then, you know, they're not, you don't give it back to them, and there are those issues. So I think that with fertile women, I think if they have a nephrologist, I think the treatment will be reinstated once the children are born, generally.
Thank you. Perhaps two angles we did not tackle. The first one, getting back to the symptoms, there is some literature suggesting that symptoms related to acute coronary syndromes may differ between men and women, and that this may delay an accurate care in women. So do you think that it is relevant for the topic you discussed today? In other words, delayed workup in patients presenting with either acute coronary syndrome or with a suspicion of stroke, for instance?
Well, towards the end of the presentation, I show you a couple of studies suggesting that women report different symptoms than men and more severe symptoms in general. And these can have two interpretations. Maybe they truly are having worse, more severe symptoms. Maybe men are brought up in a culture of being a knight and defendant of the family and less acknowledging pain. So it could be the other way around, that men have the same symptoms, but they report them to be lesser, and also, or they don't acknowledge them. And I showed you some studies at the very, very beginning showing that when the physician or the nurse is a female, the male patients report less pain. While what you say is very relevant, I think I'm not aware of enough data to support in truth these differences in symptomatology, how they would affect the moment in which we refer patients or not.
Thank you, Juan Jesus. May I ask our panelists to provide us with a final word? Annette first, then Alberto, and then you, of course, Juan Jesus. Final word?
I think this was a very excellent seminar, and just to raise these questions and that we become more aware and that we can spread this information to our colleagues, but also to the primary care, because they are the ones that either they should take care of them or refer them, but they have to know this also.
Thank you, Annette. What about you, Alberto?
Well, I found the most interesting topic because it's, if we understand it, we will be able to actually prevent CKD. It's the sex-related differences in the, let's call it, accelerating aging of the kidney. So if we understand why this is taking place, maybe we can intervene at around age 50, 60 to prevent many of the people who actually now need kidney replacement therapy from ever requiring it.
Thank you, Alberto. What about you, Juan Jesus? Last word?
I think I have said enough, and the two summaries of Annette and Alberto clearly emphasize the importance of gender medicine. We are different. We can use that as an opportunity to improve our practice, and we need to be aware of these differences also to improve the way we treat our patients.
Thank you very much, Juan Jesus. So thank you so much to you as a speaker, to Annette and Alberto as discussants.